So, a very good day to one and all. I am Dr. Rohit Gopinath, and today we'll be talking about a very important topic in pediatric surgery, malignant liver tumors. First case report of a malignant liver tumor was done by Misik in Prague, wherein on an autopsy of a child, a 6-week-old child, who died because of respiratory distress, he found that the liver was grossly enlarged and had a mass lesion within it. On opening the mass, he found that it contained hair follicles and bony elements inside it. Hence, he named it teratoma hepatis or hepatic teratoma or liver teratoma. Now, the first proper definition of the terminology hepatoblastoma was introduced by Willis, who said that this particular tumor is an embryonal tumor which is characterized by excessive proliferation of precursor cells of the hepatocytes called hepatoblasts. Until for a long period of time, we found that hepatoblastoma and hepatocellular carcinoma were often confused with each other. It was very difficult to differentiate a hepatoblastoma and a hepatocellular carcinoma. Ishak and Gluntz were the first to introduce a criteria to differentiate a hepatoblastoma from a hepatocellular carcinoma. XLB, in his famous series way back in 1975, he studied around 200 to 250 cases of malignant liver tumors, and he came to the following conclusions. Most of the cases, the death in these cases were reported to be because of excessive blood loss during the procedure. And he found that a chunk of these patients, who are undergoing procedures for liver tumors, were dying in the perioperative period. The overall survival rate, according to XLB, was a dismal 35% for hepatoblastoma and even worse for hepatocellular carcinoma. What proved to be a game changer in the management of malignant liver tumors was the introduction of cisplatin-based chemotherapy way back in 1980s. So, with the introduction of cisplatin-based chemotherapy, survival rate jumped from 35 to 70%. And on refining the dosages of chemotherapy, especially cisplatin and even doxorubicin, the survival rate subsequently jumped up to 80%. But then, there is only so much that chemotherapy can do in malignant liver tumors. Surgery or complete surgical excision is a cornerstone in the treatment of malignant liver tumors. Most of these children with liver tumors they usually present incidentally with an incidentally diagnosed abdominal mass, usually noticed by the mother while giving the child a bath. It might also be noticed by a physician when the child goes to him for a non-specific abdominal pain. Younger children, especially in infancy and the neonatal period, hepatoblastoma remains the most common malignant liver tumor. In fact, malignant liver tumors are the third most common solid organ tumors in the abdomen, after neuroblastoma and Wilms tumor. Fatigue, yes, can be a feature of hepatoblastoma like any other malignancy. Fever, because of excessive inflammatory mediator release, can occur. Pain can be there. Now, this pain can be either acute pain or chronic in nature. Acute pain can be because of hemorrhage into the tumor, and this hemorrhage can be induced by something trivial, for example, like a fall, or it can be some other forms of trauma, etc. So, this trauma or most commonly this trauma or fall will unmask a pre-existing liver tumor. Or this pain can be chronic in nature, especially if you have a large tumor mass wherein which distends the Glissen's capsule of the liver, causing chronic dull aching pain. Sometimes a large liver mass can also impinge on the diaphragm, causing back pain and even shoulder pains. Now, when do you suspect hepatocellular carcinoma in a child? If the child is an older child, for example at 10 years or more, then the chances of hepatocellular carcinoma in the child is very high. Even hepatic sarcomas are also more likely in older children. Now, not only do you get non-specific symptoms associated with liver tumors, you can get symptoms which are related to the compressive effects or the mass effect of the tumor. So, a tumor within the liver, okay, it's a confined space. So, it's growing within the liver. It can compress upon the structures within the liver. So, what are the major structures within the liver? The vascular structures. For example, you have the hepatic vein, the portal vein, hepatic artery, you have the biliary radicals. So, if there is compression of the portal vein, what happens? The compression of the portal vein results in elevated portal venous pressure, can result in portal hypertension, ascites, splenomegaly and other complications. Similarly, if you have a large lesion which is going to impinge on the biliary radicals, it can destroy the biliary radicals or can obstruct the biliary radical, causing jaundice, cholangitis, etc. Of course, if you have a child with a liver mass causing cholangitis, jaundice, etc., what would be the most likely diagnosis will be a biliary rhabdomyosarcoma rather than a hepatoblastoma. Now, these are the various differential diagnoses of liver masses. You can see that almost around 15 to 20 differential diagnoses are there as far as a liver mass is concerned. It varies from malignant lesions like hepatoblastoma, hepatocellular carcinoma, biliary rhabdomyosarcoma, angiosarcoma, to benign conditions like mesenchymal hematoma, focal nodular hyperplasia, infantile hemangiomas, sometimes even lesions which may not be of malignant or malignant nature, for example like vascular malformations, arteriovenous malformations, sometimes congenital cysts, parasitic cysts or non-parasitic cysts, choledochal cysts can be one of the causes, hematoma can be a cause, post-trauma, fatty liver can also manifest itself as a liver lesion. Now, so differentiating between these individual lesions is of great importance because identifying malignancies early is key in the management of these lesions. Now, age, like I said earlier, can give us a clue regarding what type of lesion it could be. Now, if a child or an infant or a toddler comes to you with a liver mass, or if you are suspecting it to be malignant in nature, it is more likely to be a hepatoblastoma in 43% cases. Other possibilities of other malignant possibilities or other possible malignant lesions of the liver in this age group can be a rhabdoid tumor 1% and a malignant germ cell tumor in another 1%. In older children, school-going as well as adolescent age groups, hepatocellular carcinoma, including transitional cell liver tumors, constitute around 23% of liver lesions. Sarcomas constitute around 7%.